Hi, class. This is Dr. Weaver, and I am going to be discussing with you the topic biliary and pancreas disorders. We will be particularly talking about the biliary disorders. We won't get into any pancreatic disorders in this class. It is important for you to know that the biliary and pancreatic system is all a part of uh, the um, the GI system. Now, the biliary tract, or also known as the biliary tree or biliary system, it refers to the liver, the gallbladder, and bile ducts, and how they work together to make, to store, and to secrete bile. Now, bile consists of water, electrolytes, bile acids, cholesterol, phospholipids, and conjugated bilirubin. So at the end of this lecture, I want you to be able to apply knowledge of anatomy, physiology, pathophysiology, genetic risk, age-related changes, and psychomotor skills to perform a focused assessment of the GI system. Also to describe interprofessional care and educational needs to promote nutrition for the patient with a biliary disorder. And lastly, collaborate with an interprofessional team to protect the patient with biliary disorders from injury and infection. So let's go ahead and get into the pathophysiology of cholecystitis, which is an inflammation of the gallbladder and commonly seen in affluent countries. It can be acute or chronic, although the acute type occurs more often than the chronic type. Two types of acute cholecystitis can occur. That is one type occurring with stones and another type occurring without stones, which is referred to as acalculous. And the calculus or the stones appears more often than acalculous. The most common type, which is the calculus cholecystitis, leads to chemical irritation and inflammation. And this results from the gallstones or cholelithiasis. The stone actually obstructs the cystic duct pretty often. Also the gallbladder neck, as well as the common bile duct. This is known as cholelithiasis. Once the gallbladder becomes inflamed, the trapped bile becomes reabsorbed, and it becomes like a chemical irritant to the gallbladder wall. Now, ischemia and infection results from reabsorbed bile along with impaired circulation, edema, and distension of the gallbladder, and this leading to tissue sloughing with necrosis and gangrene within the gallbladder. The gallbladder can rupture or perforate. Now, if that area is small or more localized, it can lead to an abscess, but if the area affected is fairly large, it can lead to peritonitis infection. Now, gallstones may be due to abnormal metabolism of cholesterol and bile salts. Stones might also result from normally abundant mucus with its highly viscous and concentrated bile. Now, when there is impaired gallbladder motility or movement, this can also lead to stone formation by delaying bile emptying and causing biliary stasis. Now, cholesterol stones most common a stone found in adults in the United States. Also, bacteria collects around the stones in the biliary system, and this can lead to severe bacterial invasion. And of course, this can also lead to life-threatening suppurative cholangitis if these signs and symptoms are not quickly resolved with treatment. Now, this can lead to essentially pus accumulating in the ductal system. Now, the acalculous cholecystitis, this is basically inflammation without gallbladder stones, as I previously mentioned. And this is due to biliary stasis from a condition affecting regular filling or emptying of the gallbladder. For example, if there's decreased blood flow to the gallbladder, or anatomic problem like twisting or kinking of the gallbladder neck occurs, etc. Now, the sphincter of Oddi dysfunction, this might be a cause from either reflux or inflammation and occurs with sepsis, severe trauma, and burns, etc. Now, cholecystitis of the chronic type, this condition occurs with repeated episodes of cystic duct obstruction due to normally chronic inflammation or stones mostly present, excuse me. Now, the gallbladder becomes contracted, fibrotic, and this also results in decreased motility and deficient absorption. A complication of cholecystitis, chronic is pancreatitis, cholangitis, meaning bile duct inflammation. And this is due to the backup of bile throughout the biliary tract. Now, bowel obstruction, it does lead to jaundice. And of course, jaundice and icterus occurs more in the chronic versus the acute type. So that's one of the distinguishing characteristics. Now, obstructed bile flow due to swelling or edema of the duct or gallstones leads to extrahepatic obstructive jaundice. Now, jaundice jaundice in cholecystitis can be due to direct liver involvement. Now, when the liver bile channels or bile duct inflames, this causes intrahepatic obstructive jaundice, which also results in increasing circulating levels of bilirubin, which is actually a major pigment of bile. Now, patients with obstructive jaundice have blocked flow of bile in the duodenum, and this actually leads to an increased bile salts, which accumulates in the skin. And this is what leads to the pruritus or the itching or burning sensation of the skin. And the bile flow blockage also leads to a decreased bilirubin reaching the large intestine, which is converted to urobilirubin. Now, the absence of urobilirubin, all right, the word is urobilinogen, excuse me, class. So this results in normal brown color in stool, but now, well, whenever you have this substance present, the urobilinogen is present, your stools are brown. But without this substance, your stool will become more clay in color. The urine also becomes dark and foamy due to excessive bilirubin circulating in the body. My apologies. As I said, this cold is kind of getting the best of me. So, what is the etiology of cholecystitis? So, it can be due to familial or genetic tendencies, likely due to familial dietary habits or sedentary lifestyles. Also, I would like you to look at table 59-1 on page 1193 for risk factors for cholecystitis. This condition is also seen mostly in young, thin women, especially of the athletic type, such as ballerinas, as well as gymnasts. Um, and they have this chronic pain that is often misdiagnosed as gastritis. So cholecystitis can be managed in the home setting. All these patients might need surgery, and of course, hospitalization obviously is required at this point. I want you to look at page 1193, chart 59-1, for signs and symptoms of cholecystitis. Um, Also, want you to make sure that you obtain height and weight information, vital signs. These are things that can be delegated to your unlicensed assistant personnel because they're going to be affected nutritional wise because again, this is all a part of the GI system. You want to take a nutritional intake as certain diets contribute to this condition. So you take a nutritional history. Diets that contribute to cholecystitis are your high in fat, high calories, low fiber, and high in refined white carbohydrates. Now, you want to also inquire if an intake of certain foods causes pain, such as the fatty foods. Eating fatty foods can cause gas, indigestion, belching, as well as anorexia, etc. Cholecystitis pain can be described as indigestion, varying intensity, ranging from mild, persistent ache to steady, constant pain in the right upper quadrant, and it might also radiate to the right shoulder or scapula. Now, chronic cholecystitis signs and symptoms can be vague and also non-specific, usual pattern episodic. Now, severe pain of biliary colic is due to obstruction of the cystic duct of the gallbladder or movement and one or more stones. Now, as stones move through or lodge in the duct, tissue spasms occur in order to basically it's trying to get the stone moved through the ductal system. You want to also ask women if they're taking hormone replacement treatment or birth control pills. Also, Bloomberg sign may be present. This is peritoneal inflammation that can be present, and with deep palpation below the liver border, and it can reveal this sausage-shaped mass, which is a distended, inflamed bladder. Now, with cholecystitis, chronic signs and symptoms are slow developing, and patients normally seek help with later signs and symptoms such as jaundice, clay-colored stools, and dark urine from biliary obstruction. Also, these patients develop icterus and yellowing of the oral mucosa, mucous membrane, and also fatty stools. Remember, bile is needed for absorption of fat and fat-soluble vitamins in the intestine. So when this system is not functioning well, then you will have, these patients will have problems absorbing fat as well as these vitamins. Now, these patients might have a fever. They also might be tachycardic, and dehydration from fever as well as vomiting. Patients may also decline food intake due to pain, signs and symptoms as well. So they will usually be nutritional deficient because of these symptoms. So let's go ahead and talk about some diagnostic tests that are used to diagnose cholecystitis. Similar health concerns to cholecystitis that must be ruled out are PUD, hepatitis, and pancreatitis. So these pretty much become a part of your differential diagnosis when you're trying to figure out a cause. White blood cells reveal inflammation. So CBC may be obtained to look at that information. Also, increased liver enzymes might show abnormal liver function in patients with severe biliary obstruction. There's also direct and indirect bilirubin levels are also increased. Pancreatic enzymes are increased as well. Sometimes the doctor may order an abdominal x-ray that might show a calcified gallbladder stone. Now, an ultrasound of the gallbladder shows cholecystitis, and this is seen as edema of the gallbladder wall. I said BG, but that should be gallbladder wall. And also pericholecystic fluid. Now, a HIDA scan can visualize biliary system or the biliary tree. And this is something that we want to teach our patients about this particular test. And you can see that on page 1194. Now, also these patients, the doctor may order an ERCP. And this is done for those with unknown cholecystitis or stones. And an MRCP is done as it is a non-invasive procedure. And so with this procedure, what is important is to ask the patient about allergies to contrast media or material, since they will likely be receiving this substance and whatnot. Now, as far as priority collaborative problems, we are looking at weight loss. As you remember, they're nutritionally deficient, and also we're looking at acute pain issues as well. So let's go ahead and look at some of the interventions regarding cholecystitis. So lap chole is the treatment of choice for acute or chronic cholecystitis. It does have a shorter recovery time. It's also, because it is a lap procedure, there's a decreased expense, there's a decreased post-op pain, and minimum scarring as well. As far as nutrition, lab values will show the patient is free of malnutrition and that their weight is more stable. The diet should be low in fat and also high in fiber. You want to avoid gas-producing foods, You want to provide these patients with small, frequent meals as they are tolerated better. Also provide their favorite meals because they're likely to eat more. Um, Also, we want to monitor their labs, their BUN, their pre-albumin, their also their total protein, and transferrin levels to assess nutritional status. Now, as far as helping or as far as trying to alleviate their pain, we want to keep these patients NPO if they have nausea and vomiting. We also want to place these patients on maintenance IV fluids in order to hydrate them well. Toradol is given for pain. And one thing we have to be careful about with Toradol is that it is an NSAID. NSAIDs do cause GI bleeding, so be careful about that. Now, when these patients have acute pain, of course, opioids might be the drugs of choice for these patients. The only problem is all opioids can cause sphincter of Oddi spasms, and this is what can cause pain. So the doctors may try to place them on something that maybe even a low dose of an opioid so that it does not cause this kind of a reaction. Now, there are drugs such as Actigol and Chenodol that can dissolve the stones. So what would happen is your physician may perform an ultrasound to assess the treatment's effectiveness in about 6 months, because it takes quite a while for these stones to dissolve. Now, this drug causes diarrhea, vomiting, severe abdominal pain, and radiation to the shoulders. So you want to encourage your patients to report these side effects. Now, if patients are not good candidates for surgery, then an ESWL, basically like the ultrasound waves, can actually polarize these stones. And I want you to look at the criteria for this procedure on page 1195. And so basically it breaks up the stones, small stones, to pass through the GI system, much like the when people or your patients have renal stones and they have the lithotripsy procedure. So more or less like that. So essentially we're trying to break the stones up to very small stones in order to pass through the GI system. All right. Now, a percutaneous transhepatic biliary cath or a drain can also be used to open the bile ducts and facilitate bile flow for patients who are not good candidates for surgery as well. And so this is referred to as a cholecystotomy. And I want you to read page 1195 about this particular procedure. Now, if drainage cease, the drain is likely not working, and so surgery may include a lap or open procedure, and I want you to read about that also on page 1195. Now, I want you to also read page 1195 regarding minimum invasive surgery. Want you to see the these patients who have low complications from these procedures, such as complications not common, um, uh, such as death rate being low, for example. Um, Also, CO2 retention is a complication of a lap procedure, which may cause discomfort throughout the thorax and also the shoulder. Um, Early ambulation and heat application can actually help resolve the CO2 retention. Also, monitor all post-op patients for nausea and vomiting, etc. Zofran is also given as an antiemetic. We want to also elevate the head of bed when these patients experience nausea and vomiting in order to prevent a kind of aspiration pneumonia. Now, the lap procedure will require steri strips and a small adhesive bandages, and may also have a glue to keep the incision intact. Now, older patients, older adults may require an overnight stay for laparoscopic procedures, something you're not likely to see in your younger population. Now, these patients can shower a day after surgery with the lap procedure and can resume usual activity within a week. And also see notes on procedure on page 1196. Now, traditional cholecystectomy is only for patients with severe biliary obstruction. These patients may have a Jackson-Pratt drain, is usually placed, and this prevents fluid accumulation, which is usually a serosanguinous color. Serosanguinous is basically a serous fluid mixed with blood. Now, so this serosanguinous blood will also be mixed with stained, well, it will be stained with bile within the first 24 hours. And after which the drain is removed after the surgery. Antibiotics are also given for the first 24 hours to decrease infection. And want you to see chapter 16 for usual care for any patients who are having abdominal surgery. Just kind of skim that chapter because it's pretty much the same for again, any patient undergoing abdominal surgery. These patients may also have a PCA pain pump at times to help control their pain. We want to ensure that we are teaching these patients to splint their incision, especially when they cough and deep breathe, and this will help to alleviate any kind of pain that they may feel when coughing. Also, we want to give these patients antiemetics to decrease pain related to muscle straining from the vomiting. We want to assess their incision for signs and symptoms of infection. We also want to encourage ambulation to promote peristalsis and also to prevent DVTs. Their diet is advanced from clears to solid as peristalsis returns as well. Now, in the early post-op period, these patients will have a low-fat diet given to reduce discomfort. We want to encourage these patients to avoid fatty foods like butter, fast foods, etc. We want to also teach these patients to report repeated abdominal or epigastric pain with vomiting. Also, along with diarrhea for several weeks or so or months after the surgery. They should not be having these symptoms that far out from the surgery. Also, I want you to look at page 1196, chart 59-2 for common causes of post-Coley syndrome. And also look at the ERCP that is used to treat post-Coley syndrome as well. Just take a read at that. Also, as far as care coordination and transition management, these patients, patient teaching is very important here, such as avoiding, again, fatty foods, fried foods, and also reporting signs and symptoms of post-op complications. And as far as evaluation is concerned, what is most important here is that the patient would have adequate nutrition and also a decrease in pain.